I want to go a little forward and start talking about the specific diseases. The first disease, because it's probably one of the most important diseases we see in rheumatology, is rheumatoid arthritis. And the case here is an important one. A 26-year-old woman presents with a 3-week history of joint swelling and stiffness. The PIPs and MCPs, metacarpophalangeal joints, the proximal interphalangeal joints, that's the PIPs, and wrists are involved symmetrically, which you confirm on exam. She has stiffness in the morning, about 2 hours. She has also fatigue, low-grade fever. She has no back pain or DIP involvement. So a 26-year-old woman, 3-week history of symmetrical polyarthropathy. So your differential right away says, okay, is it rheumatoid arthritis? Is it lupus? I don't have any history here of anything like a rash or anything else. And then you think about viral infections, right? We said viral infections like Epstein-Barr, like hepatitis B, and stuff like that should be thought of. Now, 2 things here that are very important. She says she has no back pain. You ask her about that because it's very important. It is very uncommon for patients with rheumatoid arthritis to develop lower back pain. They may have upper neck pain, but lower back pain they hardly ever have. And you also check for DIP involvement, and you find none in this patient. And that's also very important because rheumatoid arthritis, for your purposes, hardly ever involves the distal interphalangeal joints. Hardly ever. So that's very important. So rheumatoid arthritis, we did all the tests in this woman to tell you the finish on her. All her viral titers were negative. Her anti-nuclear antibody was negative. And then the rheumatoid factor came back, and it was 1 to 2,000, very high rheumatoid factor. And on the X-ray of her wrist, you could see early erosions, despite even having the disease only 3-4 weeks, according to her. So she had typical rheumatoid arthritis, and rheumatoid arthritis is a chronic, inflammatory, multi-system disease. The main focus, even though it's a systemic disease, I want people to remember that, it's a systemic disease, so you may have systemic manifestations like low-grade fever, weakness, weight loss, but the main focus of the disease is the synovium. You usually don't get a lot of extra-articular manifestations in rheumatoid arthritis. Now, compare that to lupus, where the patients with lupus have polyarticular involvement, but their focus, their main focus is other organs, the lung, the kidney, the brain, the skin. So in rheumatoid arthritis, yes, it is a systemic disease. You may have extra-articular manifestations, but they are few, they're not that common, and the main focus is the synovium. That's how you look at it. So the patient complains mostly of joint pain. So the hallmark, inflammatory synovitis in a symmetric distribution. What happens if you don't treat it? Well, the inflammation, right, goes on, and what happens? Inflammation in the joint, you get bone erosions. This is an erosive disease, and eventually deformities. Now, a couple of things that we have here on the slide that are very important, that have come up over the last about 8 to 10 years, is what happens in the synovium in rheumatoid arthritis. And one of the predominant cells is the T cell. The T cell seems to some way, form, or another, keep this inflammatory process, going and going. So the T cells are very important in propagating this inflammatory process, and that's why, because especially the T helper cells, that's the predominant ones, that's why in patients with HIV, when they have low CD4 counts, they never get rheumatoid arthritis when their T cells, because their T cells are involved. So if they ask us, well, what is the rheumatic disease that is uncommon to see in HIV patients, the answer is rheumatoid arthritis, because they have defect T helper cells. On the other hand, we had a patient where this patient had severe rheumatoid arthritis, And then all of a sudden, her rheumatoid arthritis really got better all of a sudden out of the blue, and this patient had gotten infected with HIV. Devastating, but her rheumatoid arthritis got better. And then the second part to that, we know now that a lot of pro-inflammatory cytokines mediate this inflammation. T cells and pro-inflammatory cytokines, things like tumor necrosis factor, IL-1 and IL-6, so which underscores some of the newer treatments that focus on the inhibition of these pro-inflammatory cytokines, things like infliximab. They block tumor necrosis factor, other ones block tumor necrosis factor in other ways. They block the cytokines. So very important, because a lot of the new treatments have focused there on this, on the blocking of these pro-inflammatory cytokines to be able to alleviate the inflammation and downregulate this whole process and do away with the erosions and the deformities that these patients get. The diagnostic criteria is easy. If you remember what we said about the disease, you'll know everything about it. We said it's inflammatory, right? So it has to have morning stiffness, at least an hour. All these things have to go on for a couple of weeks, right? So they can't be just for about a week or so or a couple of days. They want you to be for like a month and a half to make sure that this is not something transient. So everything here has to be like about a month and a half. It can't be just a short while. So the stiffness, you have over 1 hour for 6 weeks or so, and then symmetrical swelling of the wrists, MCPs, PIPs for 6 weeks, right? So they want it to be at least 3 joints, so they want it to be at least, not the oligoarticular type, and it has to be symmetric for 6 weeks. So it all falls into how we defined rheumatoid arthritis, a polyarticular symmetric disease that's chronic, multisystem, and inflammatory. That's all you got to remember. And then, of course, we said that if you don't do away with the inflammation, what do you get on the joints? Well, something that you'll see on the x-ray, the erosions. And we said the rheumatoid factor is positive, not all the cases, but that's one of the criteria. And then one other thing that you may get, this is one of the extra-articular manifestations of rheumatoid arthritis. This is a type of rheumatoid vasculitis where you get rheumatoid vasculitis and a little bit of necrosis around the vasculitis, and these are referred to as rheumatoid nodules. Patients that have rheumatoid nodules have aggressive disease. Aggressive disease. So right now you should know two reasons that a patient will have aggressive disease, 2 criteria that you should say this patient's going to have aggressive disease and I need to treat this patient really, aggressively. A very high rheumatoid factor is number 1, and then the other one is rheumatoid nodules. And then there's a third one where the patient gets early erosive disease. Within a week, a couple of months of having the rheumatoid arthritis, she or he will get early erosive disease. That's the third criteria that tells us this patient will have aggressive disease. So these are the diagnostic criteria, right? If you look at the rheumatologic literature and the textbook, they say you have to have 4 of these to make a diagnosis. But for the purpose of the boards, right, these things make sense. You have to have it for some time. It has to be polyarticular symmetric, right? So polyarticular, more than just a couple of joints, symmetric. You have to have morning stiffness, right? You'll get erosions on the x-rays, and you'll get a positive rheumatoid factor, and that's all you all have to know. If you get a couple of those, then you can make the diagnosis of rheumatoid arthritis like we did in this patient. So a couple of other things that they tell us on the boards about. So if they show you a radial deviation, they may show you a picture of somebody's hand radial or ulnar deviation with the deformities in radial deviation. They say, what is this likely? Tell them it's rheumatoid arthritis. Other diseases do that, but when they show you a picture, they're trying to tell you about rheumatoid arthritis. And then they may tell us about one of 2 things, a boutonniere deformity, right? A boutonniere deformity is when the proximal interphalangeal joint is permanently flexed, but the distal interphalangeal joint is permanently extended, like this. That's a boutonniere deformity. This is flexed, this is extended, and this is permanent. That's a boutonniere's deformity, and that happens in rheumatoid arthritis. And the opposite of that is a swan deformity, where, look at this, now the PIP is permanently extended, and the DIP now is permanently flexed, like this, like the head of a swan. So if they show us any one of those two, the answer is rheumatoid arthritis. Now, you know, I showed you the DIP, and you know it's bent over like this, or it's permanently extended. But in the boutonniere deformity and the swan neck deformity, it's not the DIP that's involved. It's a tendon here that's involved from the proximal arthropathy that causes these deformities. So don't get confused that the DIPs are not involved in rheumatoid arthritis. I mean that they're not directly involved. A couple more things about rheumatoid arthritis. Extra-articular manifestations, I said, are not as common as lupus, but we may find them. One of these is to find the rheumatoid nodule, which I told you already is a bad prognostic thing if you find in a patient with rheumatoid arthritis. It's a focal vasculitis and occurs maybe in about 1/3 or 20% of the cases, especially in areas where you put a lot of pressure on, like the olecranon bursa, right, or the occiput, right, or the Achilles tendon. Those are the areas that most likely you're going to find rheumatoid nodules. They tell you that this patient's going to have aggressive disease, so you better start to treat the patient aggressively. And the last thing I want to tell you, there are some case reports. One of the treatments for rheumatoid arthritis is methotrexate. One of the most important treatments right now is methotrexate. We start with methotrexate right away. Well, one of the things that methotrexate could do, rarely, but it has been reported, and I want you to know about it, is that once you give it to the patient, it may flare, cause a flaring of the rheumatoid nodules. Just be aware of that. So methotrexate is given, and it's good, and it's not a contraindication to give it in patients with rheumatoid arthritis and rheumatoid nodules. In fact, that's the treatment of choice, but rarely, in a very small percent of the population, it could cause a flare of the disease. Be aware of that. Felty syndrome is a triad of rheumatoid arthritis, splenomegaly, and neutropenia. And because these patients get neutropenic, they may develop gram-positive infections like staph and strep. So rheumatoid arthritis, splenomegaly, and infections because of the neutropenia. Remember that. So if they tell you, are patients with rheumatoid arthritis prone to infections? Well, they are, maybe because they're taking, you know, methotrexate and stuff like that. But also patients, if they have Felty syndrome, because they have neutropenia, they're prone to gram-positive infections. Kaplan syndrome, we discussed a little bit in our pulmonary section. Patients with Kaplan syndrome have pre-existing co-workers pneumoconiosis. This is an interstitial lung disease, an occupational lung disease, because they breathe in the coal, and it causes an inflammatory process, an interstitial lung disease in the lungs. And then, on top of that, they have rheumatoid nodules in the lung. So their lung has been affected from rheumatoid arthritis because they have rheumatoid nodules, the vasculitis, plus they have the pneumoconiosis. That's Kaplan syndrome, a combination of pneumoconiosis plus rheumatoid nodules in the lung. So what are the laboratory tests that we're going to get in rheumatoid arthritis? A couple things that we're going to see and that we're going to need. We need a rheumatoid factor. Remember, this is one of the criteria. You always want to see a rheumatoid factor positive in rheumatoid arthritis, but you can make the diagnosis with a negative one. You have all the other stuff, the erosions, the polyarticular symmetric involvement. So you can make it even with a negative rheumatoid factor, but you like to see a positive rheumatoid factor to make sure you got the right diagnosis. And the second reason you want to check a rheumatoid factor is because you want to see how high it is, because a very high rheumatoid factor tells us that this is going to be an aggressive disease. A lot of people with rheumatoid arthritis, because it's a chronic systemic disease, have anemia. What type of anemia? Anemia of chronic disease. That's the most common scenario. Be careful, because people with rheumatoid arthritis present sometimes with anemia, microcytic anemia. Don't assume it's anemia of chronic disease unless you check the iron, unless you check the ferritin. Why? Because patients with rheumatoid arthritis take nonsteroidals for their pain. So they may develop peptic ulcer disease. They may have microscopic bleeding and develop anemia. Please, all patients with rheumatoid arthritis that have anemia, check their iron indices and their ferritin to exclude iron deficiency. Iron deficiency is a different story. Iron deficiency needs a workup. Make sure that the patient doesn't have an ulcer, doesn't have cancer. If the patient has anemia of chronic disease, fine. Treat the rheumatoid arthritis, but you have to document that. If they ask us what is the likely anemia associated with rheumatoid arthritis, that's fine. The most common anemia associated with rheumatoid arthritis is anemia of chronic disease. The erythrocyte sedimentation rate is going to be always elevated. With active rheumatoid, always elevated. The x-rays will show erosions or periosteal depletion. You know, that's just the time before you get the erosions. So look for that. The more erosions, the more early, the more aggressive the disease. Synovial fluid analysis, we don't usually have to do it. We don't. In the typical rheumatoid arthritis patient that comes in, you know, from the beginning, we don't have to tap their joints unless we think something else is going on or we think the joint is infected or so forth. But if we did tap the joint, what are we going to find? We're going to find an inflammatory tap. 5,000 to 50,000 cells, usually in the 10, 20,000 area. That's what they usually go around. Negative crystals, negative gram stain, negative culture. That's the typical one. How do we treat patients with rheumatoid arthritis? This has been a big deal. A couple things. The pain medication, the anti-inflammatory medication that we give, are usually some type of nonsteroidal anti-inflammatory medication in order to alleviate the inflammation really quick. Now, one nonsteroidal is not better than another. They're all about the same in terms of alleviating pain and inflammation. They're all about the same. I put a question here about the COX-2 inhibitors. Now, you're not going to get a lot of questions about that because everybody knows that most of the COX-2 inhibitors, except Siloxybid, they've been taken off the market because the association with strokes, the association with cardiovascular events. These COX-2 inhibitors, remember, were supposed to be more protective in terms of getting peptic ulcer bleeding. So in people that were high risk, older patients, physicians said, let me give them a COX-2 inhibitor because it's more selective and it makes it safer for them, you know, to take it and not have a GI bleed. Well, you could still do that, but people are very, query about that now. They're very concerned because of the association with cerebrovascular accidents, with strokes, with coronary heart disease, MIs and stuff like that. So most of these have been taken off the market. If you need to use, there's still one left, but use with caution because still we don't have the 100% answer on this. So NSAIDs have to be started right away, and then at the same time we use corticosteroids on the patient, steroids, because the NSAIDs are not going to be enough. And we add corticosteroids right away to the patient. And then in this country, unless the patient has a very mild form of rheumatoid arthritis, I've underlined here, the mainstay of treatment will be methotrexate. So this came from a study done about 12, 15 years ago at the National Institutes of Health, where they took patients and they treated them right away with methotrexate, patients with rheumatoid arthritis, and they saw that if you put them on methotrexate right away, these patients actually in the long run do better, rather than putting them on NSAIDs and corticosteroids and then increasing the doses of all that and increasing the doses of all that, and eventually putting on other medication, and eventually at the end, months later, years later, you say, okay, nothing has worked, I'll use methotrexate. We don't do that anymore. People in this country are more aggressive. They put the patient on methotrexate right away, especially people that have a poor prognosis, like the people with a high rheumatoid factor, early erosions, rheumatoid nodules. Those patients have to be started on methotrexate. Methotrexate takes a couple of weeks to start working. So that's why you need the nonsteroidals and the corticosteroids on board before that. Once the methotrexate starts working, after 2, 3, 4 weeks, what do the physicians do? They pull the patient off the corticosteroids and they use the nonsteroidals only as needed. Somebody who has been well controlled on methotrexate, really they only take methotrexate once a week, once every 2 weeks, depending on the case. When you give the patient methotrexate, you have to check some stuff, right? You have to check the CBC and make sure that the patient doesn't have it doesn't develop a marrow problem, suppression of the marrow, and you also have to check liver enzymes because it sometimes causes an effect on the liver, liver fibrosis, transaminitis. If anything like that happens, we have to stop the methotrexate. So what do? We start the patient on methotrexate right away. What do we check every 2, 3 months for the first year? We check CBC and liver enzymes. There are other drugs that now have come into the market. Hydroxychloroquine has been used for a long time, but now people are using it more. This is an anti-malarial drug. It's also used in systemic lupus, and it can be used in rheumatoid arthritis also. And now you're going to hear about some of the newer drugs, the tumor necrosis factor inhibitors, TNF inhibitors. This is the premise that I told you before, that a lot of the inflammatory cascade seems to be continued by these tumor necrosis factor. And so now you're going to hear a lot about these medications, some kind of tumor necrosis factor. They're very expensive, but they're starting to use them especially if methotrexate doesn't work. So you're going to hear about infliximab, etanercept, adalimumab, and so forth, that people are using them in resistant rheumatoid arthritis. Please be careful. These patients, there's been associated activation of tuberculosis in these patients, so you have to check a PPD, and if the patient develops any unknown fever or anything like that, has to be worked up for tuberculosis. There have been cases reported when people were using these medications. So to summarize the treatment just a little bit, before we go on to some of the other complications we see with rheumatoid arthritis, is once we diagnose a patient with rheumatoid arthritis, we start them on nonsteroidal anti-inflammatories right away, along with corticosteroids, and then, especially if the patient, I can't say 100% of the time, but most of the cases in the United States, we will start them on methotrexate right away. Methotrexate takes a short while to start acting, so we'll keep them on the NSAIDs and the corticosteroids, and then as the methotrexate kicks in, weeks later, maybe about a month later, we'll pull the patient off corticosteroids and leave them on methotrexate as the main treatment for his or her disease. And then if they have breakthrough pain, joint pain, then we'll use the NSAIDs on an as-needed basis. People that don't do well with that, then we could start thinking about adding other stuff like hydrochloroquine, or even going to the tumor necrosis factor once they fail this. It's usually people that have failed methotrexate or they've had some complication with methotrexate that we decide to put them on some of the newer tumor necrosis factor inhibitors, infliximab, and so forth. Please, in these cases, make sure that the patient has been checked with a PPD for tuberculosis, because I told you the association with starting these medications and the activation of tuberculosis in these patients. So to finish up rheumatoid arthritis, I want to talk a little bit about some complications, especially one, this atlantoaxial subluxation, what we call C1, C2 subluxation. And this is, remember I said that usually rheumatoid arthritis doesn't involve the lower back, but it involves the cervical spine, especially C1, C2. And depending on the study that you read, of patients screened for C1, C2 involvement in subluxation, it goes anywhere from 25 to 80%. So it's definitely significant, definitely significant. Now these patients, if you subluxate your C1, C2, and then the cord gets involved, you may even develop paraplegia or quadriplegia. And before, if you go back and you ask the patient, they usually have some kind of neck pain, usually occipital pain, in the back of the head, and sometimes they tell you about radicular pain, paresthesias of the hand and sometimes of the feet, but usually it's the hands and arms, C2 radicular pain. And if you're thinking about this disease with the patient's symptoms, you start off with a normal x-ray of the cervical spine, usually with an open mouth view to look for C1, C2 subluxation. Now the way they may ask us this question is that we have a patient with rheumatoid arthritis who's going for surgery. What do we have to do before the surgery? The answer is we have to make sure this patient doesn't have any subluxation, at least with a plain x-ray, and if we're not sure what we see with a plain x-ray, then do a CAT scan. The reason is because if they have the subluxation and then you intubate them to do anesthesia and stuff like that, they may get cord involvement. So what do we do always to screen these patients? We do an x-ray, and if we see subluxation, then we have to stabilize the spine before the procedure. They may ask you differently, that same question differently. They may say a patient with rheumatoid arthritis underwent a procedure, and then the day after the procedure, the patient developed quadriplegia or paraplegia. What is the likely cause of this patient's neurologic symptoms? The answer is the patient had C1, C2 subluxation, and they didn't pick it up, and they intubated the patient, flexed the neck and stuff like that, and they developed myelopathy. So please, atlantoaxial subluxation, very common. Make sure you look for it in patients that have symptoms, any subtle symptoms, neuropathy and stuff like that. You have to look for it and stabilize the spine. And if the patient doesn't have symptoms, then look for it. If you're going to manipulate the neck, you're going to do any type of procedures. And that concludes our rheumatoid arthritis